Chronic obstructive pulmonary disease is a group of overlapping respiratory conditions which may include emphysema, chronic bronchitis, and asthma. To better understand these disorders, a look at the respiratory system in the normal lung will be helpful. Here are the components of the respiratory system. The nose filters, warms, and humidifies the air. The trachea, which is known as the windpipe, branches off into the right and left mainstem bronchi. These airways are lined with tiny hair-like projections called cilia. These function to constantly sweep particles and bacteria upward to be coughed out. The right and left bronchi further subdivide into smaller bronchi, which terminate in tiny air sacs called alveoli. There are around 300 million of these alveoli, which are pictured here as an enlargement below the diaphragm. These air sacs make up the oxygen exchange surface of the lung. The alveoli are laced with beds of fine blood vessels called capillaries. At the surface of the alveoli, oxygen and carbon dioxide are exchanged. The oxygen is carried to the heart, then circulated throughout the entire body. Carbon dioxide is exhaled through the lungs. The most debilitating aspect of lung disease, common to emphysema, chronic bronchitis, and asthma, is breathlessness. This can be caused by several factors. 1. Destruction of lung tissue. The tiny air sacs where the blood gets oxygenated are destroyed, causing air to be trapped in the lungs. This is most often caused by smoking and is called emphysema. 2. Obstruction of the airways with mucus. This is most common in chronic bronchitis, but may also be present in asthma and emphysema. 3. Narrowing, inflammation, and spasm of the airways, which is characteristic of asthma. Management of these problems is multifaceted. It includes proper use of your medications, breathing techniques, good lung hygiene, smoking cessation, energy conservation, avoidance of infection, exercise, and for some people, oxygen use. Let's continue by looking at these topics in more detail. The first step in achieving control of your symptoms is to optimize your prescribed medications. This requires good communication with your physician about your symptoms and your response to the medicines he or she prescribes. Most medications are available in different forms. If you do not tolerate one form, a different form or dosing schedule may eliminate the problem. Your doctor can help with this if you're careful to report your response to the medicines prescribed. One of the most commonly prescribed medications in obstructive lung disease is theophylline. This drug is a bronchodilator, meaning it relaxes the muscles in the airway, dilating them, making it easier to get air in and out. This drug is available in several different pill forms. Some patients experience nausea and tremors when taking theophylline, even when blood levels are in the normal range. This may be controlled with a different preparation or dosing schedule, such as taking it only at night so you're asleep when the medication peaks in your blood. In any case, your blood level should be monitored from time to time, especially if the medication is making you have tremors, nausea, or headaches. You should also be aware that some antibiotics, cimetidine, Tagamet, and phenytoin, which is Dilantin, can raise your blood levels of theophylline. When new medicines are added, ask your doctor or pharmacist if they can interact with your theophylline drug. Another variable is cigarette smoking. This causes theophylline to be used up more rapidly in the blood also. Medications for breathing problems can be administered by several methods. A common way is to inhale them directly into the bronchial tubes. This avoids the side effects which may be caused by medicines that must pass through the stomach and then be absorbed into the bloodstream. Another advantage is that they can take action very quickly. The first method of inhalation we will demonstrate is the metered dose inhaler. Inhalers deliver a preset amount of medicine, but your technique is crucial for optimal drug delivery to the airways. The method we recommend is first and always shake the canister. and blow out all your air. And position the mouthpiece 1 to 2 inches from the lips. Next, press to dispense the medication at the same time, inhaling slowly and deeply. Hold that breath for a count of 5. You'll want to wait a minute before your next inhalation. Practice this in front of a mirror until you see most of the mist is going into the mouth. Your doctor may prescribe from 2 to 4 puffs with each use. Holding the canister away from your mouth decreases the amount deposited directly on the back of the throat. It allows better mixing with air for a deeper inhalation as well. A slow inhalation is critical because a rapid, shallow breath deposits the droplets only into the large airways and doesn't give it time to flow deeper into the lungs where it's most needed. Slow, deep breaths distribute the mist much better. Holding your breath after the inhalation lets the mist settle into the airways before an exhalation forces it back out. If timing or coordination of this is difficult, which it often is, a spacer device can be used. This holds the medication suspended in air until you've had a chance to inhale it, and it reduces the need for precise timing. The aero chamber is one such easy-to-use spacer, and it's available through most pharmacies. Many people who experience throat irritation or coughing from their inhalers find that a spacer decreases the problem greatly by retaining the larger droplets and letting the smaller treatment particles pass through the valve into the lungs. First, remove the caps from both the inhaler and the aero chamber. Then place the mouthpiece of the inhaler into the larger rubber-rimmed end of the aero chamber. As always, shake the canister. Then place the mouthpiece of the air chamber in your mouth and seal your lips around it. Press to dispense the medication and breathe in slowly and fully. A whistle will sound to alert you if you're inhaling this too quickly. The device should be disassembled and rinsed thoroughly at least once a day to prevent clogging. To prevent running out of your inhaler, you can check on the amount remaining by floating it in a basin of water. A full canister will sink to the bottom. 3/4 full will float upright under the surface of the water. 1/2 full will float with the top just out of the water. With 1/4 remaining, it will float tilted in the water, and an empty canister will surface. These metered dose inhalers are fast-acting bronchodilators. They work rapidly to relax the muscles in the airway to ease breathing and enhance the clearance of secretions. For best results, these bronchodilators are taken on a regular schedule, usually 4 times per day. Extra puffs of these type medications can also be taken when you find yourself out of breath. Going outdoors in adverse weather, exposure to allergens, and exercise are a few of the triggers which may create a need for extra puffs. If you anticipate these situations, your doctor may encourage you to pre-treat yourself so you'll tolerate the activity better. Taking your fast-acting bronchodilator before doing this exercise program is recommended. These usually begin working within 5 minutes, so taking a puff at the start of warm-up should help your exercise tolerance. A few extra puffs won't hurt you, but if you notice you're requiring much more frequent use of your inhalers than is usual, this may be a signal that something else is going on. You should inform your physician and inquire about the maximum number of puffs you can use per day. Excessive use can also cause unusual tremors or nervousness, like drinking too much coffee. This is more common, though, with oral medications. There is another method of receiving these bronchodilators that your doctor may wish for you to use. If you've ever been treated in the hospital or an emergency room, you've probably used a nebulizer or aerosol treatment. This delivers larger doses of the rapid-acting bronchodilators in a mist, which is breathed over several minutes. This nebulizer is a frequently used model, which is easy to use and lightweight. It is also available in a compact, portable model with a carrying case and strap. Vials containing exact doses of the prescribed medication are also available for use with these systems. These unit dose medications are pre-measured for accurate dosage, easy use, and can be delivered to the home. They may also be reimbursable by Medicare. These compressors are easy to use. Begin by assembling your mouthpiece, medication cup, and tubing, which gets attached to the outlet. The unit dose medication, or medication mixed with saline if that's what you're using, is placed directly into the medication cup. The mouthpiece is then replaced, securely attached, and you're ready to begin the treatment. Turn on the compressor, and you'll see a mist begins to come through the mouthpiece. Place it between your teeth. Then seal your lips around the mouthpiece and begin to inhale deeply and slowly, pausing for a second at the end of each inhalation. Continue this until the medication is completely nebulized. When you're finished, take apart the mouthpiece, and at least once a day, be certain to clean it thoroughly. At least weekly, it should be cleaned with an agent that your home care company will suggest to you. A different type of bronchodilator, only available as a metered dose inhaler, is ipratropium, known as Atrovent. Atrovent works in emphysema and bronchitis to prevent constriction of the smooth muscles in the airway. It is very effective for some people, but it should be remembered that in order to work, it must be taken regularly, whether you feel you need it or not, because it works by a different mechanism. It does not produce a rapid, noticeable effect. Atrovent will not be of much use to you in a sudden episode of breathlessness. There are rarely any side effects from this medication. The last group of medications I will discuss are corticosteroids. These medications are sometimes useful in emphysema and bronchitis and are very frequently effective if there is a component of asthma. They work over several days to decrease the inflammation of the airways, which has proved to be a very significant problem in asthma. The oral form is prednisone, a potent drug with potentially serious side effects if taken over long periods of time in large enough doses. That is why inhaled steroids are preferred for maintenance therapy. However, some patients with severe disease may require oral steroids for varying periods of time. In this event, these side effects should be reported to your physician. Major weight gain, mood swings or depression, frequent urination and thirst, visual disturbances, or bony pain. Your physician will want to weigh the risks versus benefits of this therapy. Never adjust the dose without the advice and consent of your doctor. Inhaled steroids work directly in the airway. The most common side effect of inhaled steroids is throat irritation or yeast infection in the mouth. For that reason, the mouth should be thoroughly rinsed with tap water or mouthwash after every use. Another way to decrease this unpleasant side effect is by use of a spacer, as we described earlier. Inhaled corticosteroids should be taken regularly as prescribed. These also are not rapid acting, and taking extra puffs when short of breath will not be beneficial. Whatever your medication regimen, it's so important for you to know how each medicine is prescribed and why you're taking it. Knowing its expected action and its side effects makes you a better partner in your health care. Your regimen may include several other types of medications not discussed here, but please have your physician explain to you their use.